Hello, I'm Harriet Kluger. I'm a medical oncologist at Yale University. I'm going to be talking about the neoadjuvant nivolumab plus ipi versus adjuvant nivolumab only study in macroscopic resectable stage 3 melanoma, the phase 3 NADINA trial led by Dr. Christian Blanc and Georgina Long. The question at hand is whether we should give preoperative immunotherapy, postoperative immunotherapy, or perhaps even doing no surgery at all. So the NADINA study was an excellent study. It enrolled over 400 patients. It was a large multi-site investigator-initiated trial for macroscopic stage 3 melanoma. These neoadjuvant studies provide us a terrific opportunity to interrogate samples and learn about the biology of tumor and the treatment. It's fascinating to note also that this study accrued in a mere 17 months. The study compared two arms. The experimental arm gave ipilimumab at approximately 1 milligram a kilogram, with nivolumab at approximately 3 milligrams a kilogram for 2 cycles, 3 weeks apart. Patients then went on to have no dissection if they had a major pathologic response, which was very carefully defined by the investigators. They then went on to have observation only. Otherwise, they received 11 months of nivolumab or a BRAF/MEK inhibitor if their tumor had a BRAF mutation. It's important to note that almost 60% of patients had a major pathologic response and did not receive any additional systemic therapy. The comparator arm was standard of care lymph node dissection followed by a year of nivolumab. Now, the rationale behind this study was years in the making. First of all, it was conducted on the heels of a different study called SWOG 1801, where patients received neoadjuvant pembrolizumab for 3 cycles, followed by surgery and adjuvant pembrolizumab for up to a year, compared to standard of care adjuvant pembrolizumab. That study was led by Dr. Sapna Patel and was a positive study for event-free survival. The biologic rationale for the NADINA trial came from Opus and Neo and Prado studies, which were previously conducted by the same groups, where they gave neoadjuvant immune therapy, and they received the rationale from the Opus and Neo and Prado studies to give this specific dosing of ipi and nivo and to use the pathology-driven response after surgery. Now, the primary result of the NADINA study was a staggering improvement in the event-free survival at 12 months with a hazard ratio of 0.32. This is almost unheard of in the oncology world. We do need to take into account that patients who were eligible all had at least one palpable node or node that was measurable by RECIST criteria or PET-AVID. So this included a mixed bag of patients. There were some that had very aggressive disease and some that had less aggressive disease. And we need to take this into account as when we talk to our patients about whether or not they should receive any systemic therapy or any systemic immunotherapy. Systemic immunotherapy has been given after surgery for the last few years in resectable stage 3 melanoma. When we do this, we have one primary goal, and that's to increase the cure rate for melanoma. We have to do this while minimizing toxicity, be it physical toxicity, emotional toxicity, or financial toxicity. And it's really important also to decrease the recurrence rate. There's a slew of potential drugs that can be used and have been used over the years. And we also infer knowledge from the stage 4 or macrometastatic setting, where we know that dual immune checkpoint inhibitors are superior to monotherapy in terms of inducing a response. We also know from the macrometastatic setting that immunotherapy can result in possible cures and that it's superior to targeted therapy for BRAF mutant melanoma in terms of long-term survival. However, we also know that the immune-related adverse events are a challenge with which we need to contend. To take a minute or two to discuss the adjuvant therapy that's been given for stage 3 melanoma over the years, we've used a number of drugs. Interferon was used for many years, well over a decade, and is no longer used. It's toxic and did not necessarily help anybody. After interferon came ipilimumab. So ipilimumab was compared to either observation or interferon, And ipilimumab was actually superior, both in terms of recurrence-free survival and overall survival. But then subsequently, ipilimumab was compared to nivolumab, and nivolumab was substantially superior in terms of recurrence-free survival. There was an attempt to give adjuvant ipilimumab every 6 weeks at 1 milligram a kilogram compared to nivolumab alone. And that regimen actually was exactly the same as nivolumab alone. This was Checkmate 915. In terms of recurrence-free survival. We don't know yet about overall survival, but we do note that there were 4 study-related deaths on the experimental arm. And that is essentially unacceptable in a setting where patients can be surgically cured. So this regimen of ipilimumab every 6 weeks in the adjuvant setting is no longer being used. Dabrafenib and trametinib are being used. Compared to placebo, they were certainly superior in recurrence-free survival, and there was a trend towards superiority in overall survival. Data presented this year at ASCO 2024 by Dr. Georgina Long. So right now, we either use anti-PD-1, be it nivolumab or pembrolizumab, or BRAF/MEK inhibitors for BRAF mutant melanoma. Both of them clearly improve recurrence-free survival. However, the hooker is that they don't actually improve overall survival in a statistically meaningful fashion, as far as we know. So we give these drugs in order to treat microscopic metastases. But if we didn't give them in the adjuvant setting and waited until patients developed stage 4 disease, it turns out that rescuing patients when they develop macrometastatic disease using our new potent drugs that we have ends up resulting in no difference in overall survival. So early treatment of microscopic disease versus waiting until the disease becomes macroscopic at the time of recurrence does not appear to impact overall survival with the data that we have in hand right now. Those data were not available when the NADINA trial was designed, and therefore there was no observation arm, and the comparator was standard adjuvant anti-PD-1. So at present, I would summarize that we don't know whether any of these interventions actually impact long-term survival, which is the primary goal. We do need to take into account, though, that recurrence is a devastating event for patients, and preventing recurrence-free survival or even delaying recurrence is also clinically meaningful and certainly psychologically meaningful. But that does need to be carefully weighed against the risk of immune-related adverse events. So grade 3/4 immune-related adverse events on this trial occurred at approximately a rate of 30%, which is consistent with other studies that have been done with ipilimumab and nivolumab at this dosing of 1 milligram a kilogram of the ipilimumab. Now, we don't always worry about grade 3 or 4 adverse event if it's completely reversible. So if someone develops diarrhea or colitis and requires some steroids, as long as they're safe and they don't have a bowel perforation, this is completely reversible, and they go on to live their lives. The same could be said for many of the other frequent immune-related adverse events, such as hepatitis and a rash. But there are some that are irreversible and some that cause permanent damage. So the endocrine immune-related adverse events do impact people's quality of life, in particular hyperpatriotism, which in this trial occurred at a rate of 7% on the ipilimumab, nivolumab neoadjuvant arm, compared to 1% on the adjuvant arm. While this isn't a life-threatening adverse event for the most part, it certainly impacts quality of life in people who might be surgically cured and can live for many, many years. There are other irreversible immune-related adverse events. These include type 1 diabetes, cardiac toxicities, and neurologic toxicities. And while these occur at a rate of less than 1% each, we are dealing with a patient population who might not need it in the first place. So when we do the risk to benefit calculations for an individual patient, we need to try to individualize the likelihood of surgical cure and compare that to the likelihood of a recurrence, and then decide whether we want to give these drugs up front. I would say that based on the NADINA study, there's no question that giving it in a neoadjuvant fashion rather than adjuvant is superior. First of all, we're trying to treat micrometastatic disease, so the earlier we give the drugs, the more likely we are to prevent recurrence early on. The other thing that is really important about this neoadjuvant approach is that it gives us the opportunity to determine in an individual patient if the tumor is biologically sensitive to the intervention. So this the bold step of stopping treatment after 2 cycles, if there's a major pathologic response, is a major advance in the field. And for that, I'd like to commend the authors of this study. Finally, we do need to know whether overall survival is improved when we give neoadjuvant therapy. So this trial, I'm going to conclude that this trial has many major attributes. It was very well designed to compare neoadjuvant to standard adjuvant therapy. The neoadjuvant platform provides an outstanding opportunity to do correlative studies and learn about the biology of our treatments and the response to them. And in this regard, it would be very nice to see this used as a platform for future early studies. It does give us the opportunity to individualize the postoperative systemic therapy. It might also give us the opportunity to decide whether or not to do surgery at all. Shortening the duration of the postoperative therapy certainly has important advantages in terms of quality of life and finances. So what we do know for sure from this trial is that early initiation of systemic immunotherapy is superior to later initiation for recurrence-free survival. We now have 2 studies that prove this. And this is only for the macrometastatic setting. Microscopic nodal involvement, which is the bulk of the patients that we see in the United States, is a completely different analysis. We still don't know whether overall survival is benefited by giving the drugs this early. And we do need to take into account the issue of the immune-related adverse events, which occur at a greater frequency when we give ipilimumab. Going forward, it would be really nice to see incorporation of prognostic markers beyond the morphologic studies that we use for AJCC staging in order to select patients who might not need systemic therapy at all, who might benefit from a simple surgical resection. We need predictive biomarkers for immune-related adverse events to identify individuals at greater risk, and we need better measures of minimal residual disease in order to determine when to stop therapy, such as cell-free DNA. For now, I think that we still need a surgery-only arm for patients with better prognosis so that we can determine whether these need any systemic therapy at all. And if patients have a radiographic complete response, it would be nice to have an arm in which surgery isn't given at all, and they're simply treated with systemic therapy. So I'm going to conclude by saying that this NADINA approach is clearly a new standard of care that should be considered in all patients with palpable disease who are at very high risk for death from their melanoma or for recurrence of their disease. And if the intention is to give postoperative anti-PD-1, it's certainly beneficial to give 2 or 3 cycles before surgery when feasible, when the disease isn't growing so quickly that we're not afraid that surgery might not be possible if we delay by 6 weeks. The greater the risk of recurrence of disease and development of metastatic disease, the greater the benefit from a perioperative systemic therapy approach. I would say that we should still consider no immunotherapy when the risk of death is low due to the risk of immune-related adverse events and the known potential for salvage therapy when needed. We also have to be very careful with extrapolating this discussion from one disease to another. Most other diseases do not have the opportunity to rescue people if they develop stage 4 disease. And in those diseases, such as breast cancer, preventing recurrence probably equates to a cure. I do want to end by congratulating all the participants in the study and all the participating researchers. This is a really important contribution to medicine and science. Thank you.